Today, I have the pleasure of introducing Dr. Katie Liu for our April Grand Rounds session. Dr. Liu is a hand surgeon and peripheral nerve surgeon at Harborview Medical Center. After completing her undergraduate studies at Duke, she joined the UW Medical Scientist Training Program and obtained both her MD as well as her PhD in neurobiology and behavior. She stayed at the UW for her plastic surgery residency, went to Stanford for her hand and upper limb fellowship, then returned to UW in 2023 to join us as faculty in the Division of Plastic Surgery. She currently serves as director of the Northwest Institute for Nerve Injury at Harborview, as well as the director of research for our plastic surgery division. Her clinical and research focuses are on complex peripheral nerve pathologies. And today she'll share with us her expertise on time-sensitive nerve injuries. Please welcome Dr. Liu.
Good morning. Thank you so much for waking up early. Thanks so much for giving me the opportunity to present today. I am so excited to take you through this whirlwind journey through clinical, translational, basic science in my world of peripheral nerves. And I hope that by the end of the day today, you will at least think of some nerve that you encounter in your daily practice and maybe grow some new collaborations from that. For disclosures, I am the site PI for a few sponsored clinical trials. I won't be discussing these studies, but I will be talking about the basic science foundations that led to these interventions at the end of my talk. So when most of you think of the brachial plexus, you probably think of images like this, of memorizing this and then immediately forgetting it right after your exam. But when I think of the brachial plexus, especially now, I think of patients like this. This is a typical upper trunk brachial plexus injury where this patient has no movement of the shoulder, can't do elbow flexion, but elbow extension, wrist flexion extension, hand motion is totally preserved. And these are the patients that really brought the brachial plexus to life for me. This is very real. And it's crazy that we have interventions that are able to restore some of that motor function. And because it is so fascinating, that's kind of what set me on my current career path. One of the mainstays of surgical treatment for peripheral nerve injuries is nerve transfer surgery, which is relatively new within the last 2 decades or so. You can think of nerves as the electrical highways from the brain out to your muscles. And when we do nerve transfers, it's essentially an electrical rewiring surgery. It involves taking a donor nerve, which is healthy, redundant, in this case, controls wrist flexion, rerouting it surgically to the non-working nerve and muscle, in this case, the biceps for elbow flexion. So when all is said and done, the patient has to think of activating the donor nerve, wrist flexion, to get the desired movement, elbow flexion. When we talk to patients about this in clinic, I usually describe it as instead of turning on the switch in your kitchen to turn on your kitchen light, you actually have to think about turning on the switch in your living room to turn on your kitchen light. So it's a little bit confusing, but again, crazy that it works. This is what it looks like intraoperatively, just one of the many examples, the double fascicular transfer for elbow flexion. As you can see on the bottom left up here, this is the incision in the upper arm. The big nerve running right in the middle there is your median nerve. And then on top of that are your 2 branches, the biceps and brachialis recipient nerves of your musculocutaneous nerve. If you think of the median nerve as one of our donors, as a handful of spaghetti noodles, you're taking just one of those noodles, a single fascicle, and transferring that into your recipient nerves. And on the right-hand side, that's what it looks like, the little nerve fascicles being connected on those blue backgrounds under the microscope. So in order for surgery to be successful and to actually restore motion, patients and their individual biology actually have to be favorable because we're really relying on their regeneration for this to all work. So from where we suture those 2 nerve ends together under the microscope, axonal regeneration is super slow, about 1 millimeter a day or 1 inch a month to reach the target muscle. And depending on the exact anatomy of the nerve transfer that we're doing, nerve regeneration usually takes a few months. Once a regenerating axon actually arrives at the muscle, new neuromuscular junctions have to form, and this is a new synapse that happens between the nerve and the muscle to allow them to talk to each other. And at that point, clinically, we're able to get an EMG to see if that signal is now present. And around this time, patients will start to feel a muscle soreness, and pinching the muscle will actually cause some pain because finally the brain is connected to their muscle again. During this early reinnervation phase, eventually you see some muscle flickers, and then gradually over the next many, many months, they start to strengthen their muscles, hopefully eventually getting to gravity eliminated, anti-gravity, and stronger than that. So if you're looking at the entire timeline of when they get better after surgery, it's usually on the order of 9 to 18 months, and usually about 2 to 3 years until they reach their plateau of where they're going to be ending up for their maximum gain. This is the alphabet soup of our common nerve transfers, excluding the ones that we make up on the spot quite often. The green are the typical donor nerves. The red are our injured and recipient nerves, and it really depends on what function the patient has, what donor, as far as what donors they have, and then what they need based on their exact pattern of injury and their deficits. So if all goes well, we can see changes like this. In this first video, this is a patient who doesn't have any elbow flexion. He's really trying very hard. And at 12 months post-op, he has gravity, anti-gravity, and almost the full range of elbow flexion. The second example is somebody who's lacking shoulder function, so no shoulder abduction there. You'll see him try to do forward flexion as well, and he can't. And at 14 months post-op, he has better motion, definitely better than where he was, but also not quite symmetric. These outcomes are pretty good considering where they started and where they ended up. But remember that this is over a year from when they actually had their surgery. The outcomes are not nearly this good if there is a delay to getting them into surgery. They're not as good for people who are a little bit older, which in the peripheral nerve injury world, unfortunately, means people over the age of 40. And not as good if there are a lot more serious nerve injuries where we don't have a lot of expendable donors. So when I think about the avenues for improvement, I really break it down into three major priorities. The first is accelerating everybody's biology through basic science research. The second is expediting clinical care. And the third is expanding our surgical possibilities. So I just want to share a little bit of our progress in each of these domains. I think the true superpower of a surgeon scientist is putting together these puzzle pieces from basic biology and really translating it into something therapeutic. Because we have such a unique perspective being in the OR and really seeing the entire progression from the bench to the OR. So for example, in our brachial plexus patients, we're really lucky if they come find us within the first few months of injury. So if we develop some miracle drug that has to be applied within a few days or a few hours of injury, it's really not going to make a huge dent in this field. On the other hand, we know exactly what we have anatomic access to in the OR. We know the anatomy. We know what we can directly touch with our fingers. So if we're thinking about it from that standpoint, from a drug delivery standpoint, it's actually really powerful. So when I think about formulating research questions, it's actually a little bit backwards. I start with, what is this potential therapeutic intervention? What are these time windows when I could potentially deliver a treatment? And then work backwards to try to crack the biology and figure out how to help these patients. There is a huge cast of characters, as you can see here, between the nerve and then the muscle. And all of these cell types really have to work as a team for this entire process to be successful. One of the biggest challenges that we're currently tackling in the lab is this very slow rate of axonal regeneration. And this is pretty consistent across many species, ranging from 1 millimeter a day up to 3 or 4 millimeters a day. And the biggest question is, how do we make axons grow faster and better? So in the lab, we routinely use immunohistochemistry in the lab to label different cell types. I don't know if we can bring down the lights in the room a little bit for some of the images that we'll be able to see a little bit better. For example, there's a normal nerve here on the left and then a more zoomed in view on the right of the same thing. These are labeled, the purple is the axons, and then the Schwann cells, the glial cells that support each of these axons is in the green here. And on the right-hand side, it's just such a pretty picture. If you can see these purple axons being totally surrounded by these Schwann cells. And we will get our lights working. So in the animal world, we use a sciatic nerve injury model to study nerve regeneration. The way we do this is by excising a 2-centimeter segment of the sciatic nerve. And from then we reconstruct it with a bridge of an acellular nerve graft. And so we have to process and decellularize the nerve graft to make sure that when we're studying nerve regeneration, it's actually coming from the proximal new nerve that's regenerating, and also that there's nothing in that nerve graft itself that's supporting the regeneration that could confound our results. So this is what that nerve looks like. On the left-hand side is a normal cross-sectional area of a nerve. You can see the green is the basement membrane that is labeled. And then on the left, you can also see the cells that are labeled with both blue and red. And then after our processing and decellularization, on the right-hand side, you see totally acellular, all the cells are gone. You only see that basement membrane protein, which provides that scaffold for the axons to grow through. So you can just think of the acellular nerve graft as a bundle of empty tubes that the new neurons can grow down. With this animal model that allows us to study axonal regeneration, our big picture goal is to create a pro-regenerative environment to accelerate regeneration. In this landmark Cell paper that came out about a decade ago, they laid out the necessary and sufficient steps to be able to allow this process to happen. So it all starts here with hypoxia within this area of injury that induces first angiogenesis, which you can see in the purple tubes here. Along these polarized blood vessels, the Schwann cells then can migrate and lay down the tracks. And finally, the axons just kind of follow the Schwann cells and eventually reach their target. Our idea was to create a patch that can be placed around the nerve, exactly where we usually are doing our nerve suturing under the microscope. And the building blocks for our engineered solution are, first, a collagen base that provides our structural support. And then we wanted to add in 2 additional types of cells to support this entire process. The first are endothelial cells, human HUVECs, to support that first step of angiogenesis, as they are the component of blood vessels. And then the second type that we really wanted to use were Schwann cells, but it actually turns out that they're really tricky to keep alive in cell culture. And so we had to change gears a little bit, especially when we're trying to culture them together with endothelial cells. So we use mesenchymal stem cells instead, which can be programmed to take on a Schwann cell-like phenotype. So we felt like this was a good substitute. And because they've shown a lot of promise in a lot of other areas of regenerative medicine. So with these 3 components in place, this is our first generation cell patch. Here you can see that there is a layer of mesenchymal stem cells labeled in red on the bottom here. And also on the bottom, as you can see, as it's rotating, and then endothelial cells, which are green labeled on top. So this is cool, this is great, but we wanted to get even fancier and make 3D microvessels, really going back to that initial study, thinking about how those polaroid vessels are really the first step in nerve regeneration. And so we collaborated with Dr. Sam Rayner over at South Lake Union, and we actually took the collagen base, we stamped it into these linear vessels and used that mold through which we flowed the endothelial cells. So they're essentially flowing through these lumens, sticking on the inside, and then creating these little microvessels. So we tried and we failed a lot over and over and over again for many painful months. We tried everything. We changed the collagen. We changed how big the lumens were. We changed how quickly we were flowing the cells through. But for some reason, we still couldn't reliably get the linear microvessels. So eventually we decided to switch our pattern to see if it would work. And luckily it did. We ended up with a grid pattern, and our current theory is that because of the flow dynamics with the linear versus the grid pattern, the endothelial cells just didn't have an opportunity to adhere when it's flowing so quickly through the linear channel, but in the grid pattern, it's actually able to stick and run into interference, so it's able to make these vessels for us. And in another pretty image, you can see the endothelial cells again are green and purple in this grid pattern. And then the mesenchymal stem cells are labeled red in the little windows in between. And on the right, it's like scrolling through a CT scan, looking at cross sections and multiple planes. You can see that there are nice endothelial cell lumens that are patent, which are essentially these microvessels in this grid pattern. And then one additional cool video looking straight down that lumen, you can see that there's pretty sturdy coverage of the endothelial cells that have really populated within this lumen. And then the mesenchymal stem cells are outside of the microvessels in the interstitial space. So with the cell patch in place, at least working in a dish, we started some pilot animal experiments. Again, we're using our 2-centimeter nerve gap with the immediate acellular nerve graft reconstruction across that gap. And then we had 3 groups. The first is control suture only. This is a rat sciatic nerve that has this white part is that acellular nerve graft that was implanted. The second group was a cell-only patch that has both the mesenchymal and the endothelial cells, but is not patterned. And then our final group was the patterned cell patch. Um, this design was really to see, is it the cells that are there that are supporting this nerve regeneration, or is there something about having that microvessel patterning and structure that's actually supporting it? And so for this one pilot round of surgeries we've done to date, we only looked at two really early time points, day 4 and 11, just to see first if this would even work. And I don't have a lot of data from that to show you, except to share a few very early observations. For the first one, you can see that just by eye at both days 4 here and 11, the patch is here. So this is the proximal nerve. This is the nerve graft segment. This is the distal nerve. And the patch you can see here on day 4. Day 11, a lot more vascular changes and inflammation, but the patch you can still pretty clearly visible there, which I think is good because it means that the body is not breaking down and resorbing this implanted substance within the first 11 days at least. The second thing we looked at is to see whether the cells actually survive once implanted. And here, if you think about a cross-sectional area through the nerve here, we're looking at sort of that top slice where we're trying to capture a good portion of that patch. And when we stain them for endothelial cells here on the left in green, for mesenchymal stem cells and right on the red, on the right in red, you can see that both of those cell types are still there. So assuming that they're still contributing to generating this pro-regenerative environment, at least out to day 11. One thing that we're also looking at is whether these mesenchymal stem cells, when they're implanted within this environment of nerve injury, whether they differentiate to become more Schwann cell-like. So those studies are ongoing. And then finally, when we look at the entire nerve, we're looking at the proximal, where it was healthy along that entire nerve graft segment, and a little bit of the distal nerve. Proximal is left, distal is right. You do see that the axons seem to regenerate across the site of nerve coaptation. Here, you probably can't see super well with the lighting in this room, but I've highlighted where that collagen patch seems to be under the microscope. You can see a little bit of a fluffy layer on these longitudinal cross sections of the nerve. Where that collagen patch is sort of along the edges if you're thinking about the nerve as a tube. And then the dotted line is where I think that nerve coaptation was. You can see proximal to that, you have tons of normal looking nerve, and then distal to that, it's petering out a little bit as it's starting to regenerate. And we're doing some more validation steps to make sure exactly where that junction is and exactly where that collagen patch is. But if you zoom in, you can see that, again, from proximal to distal, the axons are labeled in purple again. Proximal, you have tons of axons. In the middle, you do see a lot of very nice dense axons, and then very distally, I'm not sure if you can see very well in the room, but there are little smatterings of purple, and that's really the distal regeneration front. So lots of efforts currently ongoing to slice, stain, image, and analyze the first 12 rats that we did in that first round of surgery. And as a natural complement to the patch that we've chosen, the cells that we've chosen for the design, the hypothesis being that these cells are providing that pro-regenerative environment, we wanted to find out what types of proteins and neurotrophic factors might be secreted by these cells. So to study this, we culture these cell types individually and also together in case they have a synergistic effect on each other, in case one cell type is releasing something that makes the other cell type do something different when they're put together. We collect the supernatant fluid from the cell culture, and then we isolate the exosomes by a series of steps. The exosomes are extracellular vesicles that contain proteins, lipids, RNAs, and they are useful for signaling between different cells. And then with these exosomes, we essentially have a pellet there that we can then add to different types of cells to see what those effects are. For these experiments, we actually used induced pluripotent stem cells, a totally different type of cell, and differentiated those into motor neurons. And along the process of differentiation, we can see these cells as a little ball, which we call a neurosphere. Here you can see an example of a neurosphere on day 3, 9, and 16, where the cell bodies are all clustered into this core, and then the axons shoot out radially from that core. And so we can use this to look at axonal growth in a dish. To quantify this, we measure the difference between the outer axonal extensions, which I've outlined here, minus the cell core, which is also outlined. And with our imaging software, we can quantify that area of axonal outgrowth. So to these neurospheres, we applied the exosomes that we had collected from each of our cell types to see if we could actually enhance axon growth. And the results were pretty dramatic. Taking you through our data so far on the y-axis here, it is the area of axonal growth. Again, that little donut that I showed you on the last slide On the x-axis is day from when we seeded the neurospheres and began our exosome treatment from day 1 to day 6. We had 5 different conditions. The control here is in the gray. You can see that they definitely shoot out their axons, but not quite as well as the other groups. In the red here, these are from the mesenchymal stem cells alone. The orange represents the co-culture of the mesenchymal stem cells with the endothelial cells. And both of those show way more growth than the control group. The green here is from the endothelial cells. And so you can see that they're growing in the early time points. They might be helping and growing a little bit faster than the controls, but definitely not as dramatic of an effect as the mesenchymal stem cells. And then the other group that we added to this experiment was actually just throwing the neurospheres and the mesenchymal stem cells together in a dish. Is that enough to give some of that effect? And what we found was that, yes, it does seem to help, especially at the later time points, but not in the earlier time points. And our thought is that the mesenchymal stem cells, as they are in a dish, they do take some days to proliferate and start releasing all of those factors. And it probably takes some time to get to a high enough concentration to be able to actually affect the neurospheres themselves. So when we look at some representative images on days 2, 4, 6 for each of these conditions, you can see the control definitely shooting out some of those axons, but then the exosomes and the from the mesenchymal stem cells, especially in these 2 columns here, much more dramatic and not projecting on the screen nearly as nicely as on my computer, unfortunately. I think taking away from this, we have a really powerful finding in that we can actually isolate these exosomes from different cell types and hold them in your hand. We can apply them to a totally different cell type, and it has such a dramatic effect on axonal growth. So from this, what I really see right now from where my vantage point is a fork in the road on how to translate this into something therapeutic. First, you can look at all the key regenerative proteins that we can isolate from these exosomes and see what is responsible for these changes. So to that effect, we use proteomics and identified all of the proteins that are present in those exosomes. In the analysis here, we're comparing the full change of the proteins in the exosomes derived from these mesenchymal stem cells compared to those from the endothelial stem cells because those are endothelial cells because that was the greatest difference. And on the right-hand side, you can see in these highlighted circles, these are different proteins that are involved in axonal guidance, Schwann cell guidance, neuromuscular junction formation. So it's really exciting that we have a number of interesting candidates. And so I'm really excited to delve into this more from a drug delivery or just drug discovery standpoint to see if we can isolate a new key molecule that can actually help with nerve regeneration. The other fork in the road, I want to thank all the plastic surgeons based at Mon Lake for helping me out with this idea. The thought is if the mesenchymal stem cells have some superpower and they're secreting these pro-regenerative factors, can I harvest a patient's own stem cells somehow and then figure out a way to process those, put them on the nerve when I'm operating them, and provide that supportive microenvironment to make the nerves regenerate better? And luckily, adipose tissue turns out to be really rich in mesenchymal stem cells. So it's very lucky that I have a lot of friends that do a lot of liposuction. And even more lucky is that if you look at all of the components of the lipoaspirate that you get from liposuction, this top part, the mature adipocytes, that is what is actually useful in surgery for fat grafting. And that's completely separate from the stromal vascular fraction that you can see here in the pellet that has all of the stem cells. So that is usually suctioned into the waste canister. So it's really convenient that I have an RIB now that we can collect this waste. Last week, we collected our first lipoaspirate waste, and I never expect new protocols to work the first time. Day 1, it looked like a lot of cell debris and a lot of dead cells, but when we washed it, actually, there were a few little guys hanging on maybe. Day 3, we looked again, maybe there is something there, and then day 5 was just yesterday. It does look like there are some cells that are alive and proliferating, so really excited about that. Luckily, you can see the cell shape here looks somewhat like the mesenchymal stem cell morphology that we would expect to see, so I'm really excited for all the projects that we have going down this path. Okay, switching gears from basic biology back to clinical care. While we're working on all of these innovations in the lab, what can we do to improve the lives of patients now? The surgical evaluation for patients with nerve injuries can be distilled down to this, and it's pretty simple. Is recovery expected? We have a series of different diagnostic things that we do, including physical exam, electrodiagnostic studies, and imaging studies to predict whether or not somebody will spontaneously recover function. And obviously, if recovery is expected, then we don't do surgery. If recovery is not expected and there is a surgical option available, then we offer surgery. And most importantly, earlier surgery leads to better outcomes. And so as soon as we can determine that there is no chance of spontaneous recovery, for example, if you got stabbed in the arm and your nerve is in two pieces, there is no reason to wait at all to see whether or not it'll recover. You can go right away. The optimal timing for most closed injuries when we're not quite sure whether or not there's been a complete break in the nerve is within 3 to 4 months of injury, which I feel pretty strongly about. I think more generally in the literature, it's accepted to do that and stretch out a little bit longer, up to 6 months. So we'll say 6 months is the gold standard. As you can imagine, Harborview being the only level 1 trauma center serving the entire WWAMI region, care delivery is a challenge. A lot of our patients come from a lot of different places really far away for this very super specialized care. And then our regional physicians and providers don't always know where to refer and how soon after injury to refer. And in the literature, in hand surgery, delayed referrals is a huge problem, and about half of our patients never make it to see a surgeon within 3 months of injury. If you think about when you see a patient in clinic and how much OR logistics it takes, that's really, really late. And then more than a third don't even get their surgery within that critical 6-month window when they need it. Interestingly, the studies also show that the delays are greater if the initial trauma injury was treated at an outside hospital rather than a level 1 trauma center, assuming that the level 1 trauma centers will have a clinic like this to take care of these patients. And then also interestingly, that if an EMG was ordered first before the referral, that seemed to delay things, probably because you have to schedule the EMG, get the results, and then do that second referral out to a nerve surgeon. So from all of these challenges, we saw a real opportunity, and that's where we created a single center with all of the specialists to really take care of the many aspects of this complex care, from diagnosis to surgery to rehabilitation. Really excited to introduce members of our comprehensive multidisciplinary team, which is very unique across the country amongst all the nerve teams that we routinely work with. We have 4 surgeons spanning hand and plastic surgery as well as neurosurgery. We have 2 rehabilitation medicine specialists who do a lot of our very specialized diagnostic studies. They also see our patients and talk about general rehabilitation and nerve pain medication management. We have 2 radiologists that we partner with to protocol all of our studies and help with interpretation, that we have dialogue with to be able to really get down to what surgical decisions that we need to make. We also have rehabilitation psychology, which has been a huge benefit to our patients, as well as hand and physical therapy located at the same clinic. As far as our workflow, this was actually inspired by some of the multidisciplinary cancer clinics that I experienced when I was a trainee here as a medical student and as a resident. And so we try to get all of the diagnostic workup done before their clinic visit. If they're coming from afar, we really try to do behind the scenes coordination so that it's just one trip, get all their studies done, do the big clinic visit, and then go home with a plan. We do have a care conference on Thursday afternoon where we talk about all the patients and the surgeons debate about the surgical options. And then Friday is our big clinic day where every new patient sees all of these comprehensive teams. We have an opportunity in clinic to get EMG and ultrasound if needed. And then we have pathways and established partners in interventional pain, shoulder surgery, foot and ankle surgery to fast route patients where we don't have necessarily a nerve surgery solution, but they may benefit from some other intervention. And my goals for patients needing nerve surgery are diagnostics really early at 3 to 4 weeks post-injury. If you're seeing positive prognostic factors, you're pretty sure that they are going to recover spontaneously, which is good to get that at an early time point for the patient's reassurance and to really start rehabilitation earlier. That first clinic consultation within 6 to 8 weeks, again, knowing that the lead time for planning surgical OR time for especially the really long cases, surgery performed within 3 to 4 months of injury, and then hand and physical therapy from that first post-op appointment all the way out throughout their entire recovery process for 2+ years. Some of the things that we've done to make it as easy as humanly possible to get patients in to see us. There's an EPIC referral. Please refer to peripheral nerve clinic. There's no more thinking, do I refer to hand, plastic surgery, neurosurgery, rehab? peripheral nerve clinic, one-stop shop. We also have this brachial plexus and lower extremity peripheral nerve injury algorithm on Occam, which you can scan on this QR code here, that breaks it down whether people are seen in the ED versus as an inpatient, whether it's an open injury, a closed injury, and some initial recommendations for pain management. We also have a centralized email address, HMC Harborview Medical Center nerve at uw.edu, which we distribute widely to try to get community providers, therapists, even patients themselves can email in. And this helps us keep track of referrals that otherwise might get lost a little bit in the ether. Thanks to Harborview for supporting us. We have a new ultrasound machine that is very high resolution, enabling us to look at these nerves in very excellent detail. Here you can see a median nerve in the forearm. You can see one distal stump. You can see one proximal stump. Clearly, this is a nerve that is no longer in continuity. So in this case, would be going to surgery sooner rather than later. This is the old school MR brachial plexus, where you can see pretty crude cuts and not a great resolution of a brachial plexus injury. It looks like the nerves are sort of bunched up as the arrows are there. But we worked with our radiologist to implement some new protocols to give us even better resolution. And so on the left-hand side, you can see this is a special scan that is looking at the nerve rootlets. The white is the spinal cord, and then the little rootlets, you can see like clusters of 5 of them coming out on either side that is dark and black. Those are the nerve rootlets that come out and form the nerve roots of the brachial plexus. And then on the right-hand side, you can clearly see outlined there, the nerve rootlets are totally avulsed from the spinal cord itself. This A tells us that the nerve is no longer in continuity, and B, this means that we don't have some of our surgical options as far as nerve grafting exploring the brachial plexus. So this has been a huge game changer for us. As far as our progress so far since we started the Nerve Institute, we looked specifically at operative brachial plexus patients. We compared the 2.5 years prior to starting this Nerve Institute and the first year of the Nerve Institute being in existence. And we're pretty excited to see that we are actually getting these time-sensitive injuries into surgery sooner. So looking at the time from injury to date of surgery, it used to be about 7.7 months. Now it is less than 6 months. 76% of our patients are getting their surgery within 6 months of injury. Again, the gold standard in the literature. Importantly, when we see that person in clinic and make that decision, yes, you need surgery now, we now are pre-planning for that. So we're usually able to get them into the OR within 2 weeks compared to about 2 months before. And we are supporting them not only through surgery, but through therapy as well. In that their first post-op visit around the 2 to 3 week mark, they're all getting hand therapy, whereas before that would be started about a month and a half after surgery. But there's still more work to be done, as always. You can see the very top line of that was the time between injury and that initial clinic consult. And looking at the Nerve Institute, we haven't really moved the needle on that one, at least in that first year. There's this huge difference, as the literature has shown, in patients initially treated within the UW-HMC system versus ones that are referred from outside, and that's a 2-month difference. So if you think about the impact of 2 months on an individual patient, that is actually huge. The one other aspect of progress on the clinical realm that I'm really proud of that I want to highlight is the comprehensive care that we're able to provide. And so in the literature, looking at brachial plexus injuries, we're realizing that the psychosocial impacts of these injuries are huge. There's chronic pain, there's disability, inability to work. People have a lot of depression and PTSD if it's from a traumatic incident. And so disability is actually correlated with more of these psychosocial aspects than the severity of the injury themselves. In fact, there are studies that show that if you do the exact same nerve transfer surgery on 2 patients, the patient who is struggling with depression and anxiety, their motor function outcomes are worse. Can't explain it, but that's what the studies show. So having rehabilitation psychology integrated into our clinics, seeing 100% of our new patients has been really powerful. It's removing at least some of the stigma that's associated with psychology because all of our patients see it. Talk to them if you want, don't talk to them if you don't want. But in general, the topics that are discussed involve mostly adjustment to injury, non-pharmacologic pain medication strategies, coping, stress management, sleep management, things like that. We also did a survey study for 50 patients who came through our clinic, wanting them to rate on a 0 to 10 scale. How valuable do you think rehab psych will be? And we asked them before you met the rehab psychologist and after you met them, 10 being the most valuable. You can see that there's one outlier here that is in the gray who had very high hopes and apparently was very disappointed. But everybody else in this cohort of 49 other patients, they seem to have overall very positive experiences having rehab psychology. With the last few minutes, I wanted to briefly touch on our progress in expanding our surgical possibilities. I think first, this includes a lot of patient populations that I had never seen in residency that I've only heard about through the literature and going to conferences that are actually able to be helped with our nerve transfer surgeries. So it really is, once you build it, they will come, and it has been such a great learning experience. The first has been directly related to having a neurosurgeon on our team, in that you can have something called postoperative C5 palsy after cervical spine surgery. The thought there is, as you're manipulating the different cervical spine segments for the C-spine surgery, you can irritate and sometimes cause nerve injuries to the nerve roots themselves. And after a period of time, they may or may not get better. I think the dogma in the field is that, at least with the neurosurgeons and the orthopedic surgeons doing these spine surgeries, is everybody gets better at 2 years. Don't do anything. Absolutely do not touch these patients. But there are a lot of studies coming out to show that if you have zero function by about 6 months, you're probably not going to get it at 2 years. So these patients are super interesting in that they're a little bit older. Their pathophysiology is a little bit different, but we do very similar nerve surgeries to the ones I showed you. And here you can see some of those outcomes, all in slightly older individuals, but they're regaining function way faster than we would expect for somebody with a brachial plexus injury. This is something that I think about all the time when we're doing these surgeries and we're collecting samples from these patients to see what is really different about the nerves of these patients, what is helping them stay restored and getting this function back so much sooner, and maybe using that as a key to unlock other therapies for the traumatic brachial plexus patients. Here's another example of a right deltoid that is not working preoperatively, and at just 4 months post-op, that right side is pretty much symmetric to the other side. And I almost fell out of my chair when this patient came back to clinic because I didn't believe that this was real, but it is. The second big clinical realm are nerve transfers for spinal cord injury. This is very similar in peripheral nerve injury, in that we're doing similar types of nerve transfers, but in this case, the injury is at the spinal cord central nervous system itself. The thought here is that we are taking a working redundant nerve that is under volitional control above the level of the spinal cord injury and actually transferring it to something that is no longer functional below the level of the spinal cord injury. So this is preoperative videos from one of my patients. You can see difficulty with triceps extension, especially against gravity. In the middle here, he's trying to open up his hand, but he can't extend his fingers. And the last one on the upper right here, you can see he's has a little bit of finger flicker there, but not useful grasp. And then at 1 year post-op, his elbow extension is much better. His hand opening is also better, and he's definitely able to use his hand better generally for grasp functions. He's still continuing to get better. The last time I saw him was about 1.5 years. One of the biggest issues with regards to clinical research for nerve transfers is that you can't really measure this on any sort of a motor physical function scale. The things that he tells me about when he comes back to clinic is, last time I saw you, I had to lick my fingers to pick up my pill and take it, but now I can just pick it up and I can have that grasp and that function. So how do you really capture that in a clinical realm of trying to study these? The biggest other frontier that we have embarked upon are lower extremity nerve transfers. We are now seeing a ton of foot drop patients, and we have done a number of these. And the one, I don't have any good videos, unfortunately, from our foot drop patients yet, because I think the furthest one out is maybe a little over 1 year, so a little bit too early to see those long-term results. But recently, we did do a sciatic to femoral nerve transfer. Here on the left-hand side, you can see that he has complete inability for knee extension here. This was a traumatic injury where there was a lumbosacral plexus avulsion type injury. So we got him into surgery around the 4-month mark. You can see distally, he actually has really good function of the ankle and the toes. And at a year and a half post-op, he has anti-gravity knee extension. He feels like his life is pretty much back to normal. When you look at his two legs, definitely there's asymmetry. There's still weakness, but this is still early along that 2 to 3 year trajectory. And on this right-hand video, he's working with our physical therapist with some resistance bands. He can actually balance on that one leg and stabilize his knee and extension enough to be able to do that. So this is pretty exciting. This was a nerve surgery that I don't think we've ever done before. This one, where we're taking a nerve, tunneling it through the thigh from the front side to the back side, right next to the femur, and then connecting the nerves on the back side. And again, when you think about how microscopic those nerves are and the ability for these nerves to regenerate, it's actually quite remarkable that we can get results like this. Finally, I want to talk about our active clinical trials. And as I mentioned in my first disclosure slide, we are a participating site, and these are industry sponsored. I do want to give a shout out to our Unified Hand Service. We are 8 hand surgeons who are practicing at UW and Harborview. We are 4 plastic surgeons and 4 orthopedic surgeons that work very collaboratively together. And I'm very proud to say that we have 100% participation from my hand surgery partners for both of these trials. As I also mentioned before, I won't discuss the details of those studies, but more the theoretical mechanisms and the decades of basic science research that have gotten us to this translational point. The first concept is electrical stimulation of the peripheral nerve. So for regeneration to occur after a peripheral nerve injury, the neuron actually needs to switch from a signaling phenotype, where it's just conducting these electrical signals, into a pro-regenerative phenotype. And this involves a whole bunch of basic science molecules and upregulations at the cell body level in the spinal cord to stimulate this process. And the cell state switch actually usually takes about 1 to 2 months to actually make that switch. But when you do electrical stimulation proximal to the site of the nerve injury, that gets transmitted somehow retrogradely back to the cell body, and it's able to upregulate those regeneration-associated genes much more quickly. Interestingly, it kickstarts this regeneration process, but the axons themselves, after they've started regenerating, they don't actually regenerate faster. They're still limited by about 1 millimeter a day for some reason. Not sure why. So there's still a lot of really a lot of potential for new therapeutic developments in this realm. To date, in this review article, we looked at a few non-industry sponsored RCTs. There are 4 of them to date that have looked at the effect of electrical stimulation to speed up nerve recovery after both decompression and nerve transection injuries. And the data has been promising, so we'll see how this trial pans out down the line. The second thing involves a compound that many of you know and love, polyethylene glycol. This is a little bit magical, and I'm not totally sure how or whether it really works that well. But after you have a cut nerve, the 2 ends of the plasma membrane seal off, and they're no longer able to communicate with each other. But with a series of solutions, the first we irrigate with a calcium-free solution that opens up those plasma membranes. Then we apply the PEG solution, which causes axonal fusion here at the site of that injury, and then we rinse with a calcium-containing solution, which essentially rearranges the plasma membrane outside of that that area of injury somehow magically, and it plugs all the gaps in the plasma membrane, and then you get axonal continuity. So for this particular application, it is useful in things like acute nerve transection, where you have 2 live ends of the wire. You are getting to it within about 48 hours of injury before the nerves start to degenerate. Less useful for these chronic brachial plexus type injuries, where we're seeing them weeks and months out. The scientific rationale in animal studies, here is a paper from more than a decade ago that looks at electrodiagnostic study where you're stimulating the nerve upstream of your repair immediately after you do this PEG fusion. And you can see that there is a rise in the amplitude of that nerve conduction immediately after. So there's something working, that there's something that is happening compared to that negative control that's highlighted in the orange there. But it's not as good as obviously before the nerve was cut. It's about 50% of that amplitude. And then when they looked at long-term, more functional behavioral studies, the yellow highlighted ones here are the ones that got the PEG, and they do show faster and better recovery, at least out to 12 weeks post-operation in these studies. which is exciting and very interesting from a basic science standpoint, but then it leaves so many other questions, which I don't know the answers to. I've read a lot of these papers and I still can't quite figure it out. That being, what percentage of those axons within that giant bundle of spaghetti noodles are actually being fused efficiently with this? Doesn't matter if you have a tiny digital nerve or if you're repairing the sciatic nerve, which is about this big in your thigh. What if there's a mismatch? So if you have a motor neuron, but then it accidentally fuses to a sensory neuron where you're applying the PEG fusion, it's non-specific. How do they know to go to each other? Or is it totally random and you're actually doing worse by having some sort of a PEG fusion rather than letting the axons find their ends? And then why do you have this immediate electrical stimulation, but then that postoperative recovery is not immediate even in the animal studies? Because theoretically, if you're fusing those axons, you're restoring axonal continuity immediately, then you should have immediate function. So patients should be able to walk out of the hospital or use their hand right away, which we don't see. So a lot of questions, really excited to see what happens with this trial as well. Okay. So to conclude our journey this morning through the world of peripheral nerve injury, I just want to say that I'm so incredibly grateful to be able to be a part of this work and this big adventure, really stretching into this adjacent possible of the surgical techniques of things that I'd never seen in training that we are trying to figure out. And every week, every clinic brings new questions and new curiosities. Through our clinical trials, we're able to simultaneously contribute to advancing the knowledge in the field while also providing the state-of-the-art current best care that we can for our patients. We're innovating how we deliver this comprehensive care in a timely, efficient, streamlined manner and throughout the entire injury journey for these patients from diagnosis to surgery to rehabilitation and really approaching care more holistically. And finally, after optimizing all these opportunities for where we're able to deliver care and the best of what we currently have available, from there we can think about potential biological targets to continue to further develop, translate, and transform the way that we can treat these peripheral nerve injuries. In conclusion, thank you to everybody that's pictured in these photos and the people who didn't make it into these group photos. On the top left is my lab research team, my small team, as well as the greater neuromuscular disease research group that I'm a part of with 3 other PhD PIs. The clinical research team, especially the Harborview team that is doing so much work with both of our clinical trials, and then our nerve clinic team, which is not only the physicians, therapists, clinicians, but also the nurses, the clinic staff that do a lot of the behind the scenes care coordination, our medical student research fellows who are in clinic every single week enrolling our patients. And finally, thanks to the leadership in the Division of Plastic Surgery and Department of Surgery for allowing me to be a surgeon scientist. Thanks so much.
Wow, Dr. Liu, that was amazing. I have to say, listening to you and watching that description of basic science to clinic expansion to expanding the surgical technical aspects, it's exciting and inspiring. And I'm sure it is for me as for the rest of the fellows that are here. And it's an example of, I think, you give us an example of what it means to be a surgeon scientist and being able to describe and accomplish the work that you're doing in basic science. And I have to say, many times in a basic science talk, I get lost and then kind of zone out. And I didn't, I was following you all the way along. So that's better for me. So you do a really good job of describing what you're doing with basic science and how it connects to the clinical programs that you and your team are developing. Congratulations. We're proud of what you're developing here. 2 questions. One is because so much of what we do as surgeons, we get to see an immediate result. And I'm thinking about what it's like to do your reconstructive procedures and wonder whether 6 months or a year later, you're going to see the result that you wanted to see. And I know you're working on accelerating that, but how do you manage that yourself and for the rest of the care team and sort of the prolonged period of time of kind of waiting to see what the results are going to be? So that's my first question. And the second is the two nerves that I care a lot about. I'm wondering if you can tell us where we are in those, phrenic and recurrent laryngeal. So those are two nerves that I deal with a lot. How are we with effectiveness of regeneration and reconstruction of those nerves?
Excellent question. I'll start with the second one because I don't know the answer, but I will do some reading and get back to you. I think the phrenic nerve is something that is currently being studied within the context of spinal cord injury, because obviously if you have a non-working phrenic nerve, your diaphragm doesn't work, you are stuck on the ventilator. So there are a lot of different thoughts about how to potentially reinnervate the phrenic nerve to allow the diaphragm to function again, things that are pretty far out there. Interestingly, the phrenic nerve actually doesn't behave quite like all the other peripheral nerves for some reason, in that electrical stimulation of the phrenic nerve doesn't actually accelerate nerve regeneration. So the phrenic nerve seems to be pretty special in some way. So I think a lot of the principles that we know from the basic science literature will eventually potentially translate, but we're not sure which of those. As for the other question about the prolonged time duration, that was, I'm 2.5 years into practice now. For the first year and a half, it was very tough. And for boards collection and going to my board exam at a little bit over a year after being in practice, saying, I don't know, this is what everyone is doing in the field. These are the ones that are accepted, that are, we did the best that we could based on what we know. I talked to people and have senior partners who have shown me how to do some of these surgeries and just hoping for the best. I think now with how many nerve transfers that we're doing, I feel much more comfortable inventing new nerve transfers, knowing that the principles, if I'm doing the suturing correctly, that I'm really cutting outside of the zone of injury, that I'm putting two ends together, that I feel very confident about. I feel very good about reassuring my patients. We get a really early EMG at about 4 months to see whether that nerve has actually grown out to the muscle. So while that can't really predict your long-term 2-year recovery, I can say, well, at least the surgery worked because the two nerves that I put together, there is some conduction there. So not quite waiting 2 years, more waiting about 4 months, which is still a really long time, but I've accepted that, you know, all of my life has been delayed gratification if you think about my training.
I just want to let you know how immensely proud we are as a division to have you doing research here. The part that I think that for the trainees to think about is the incredible accomplishment of 2.5 years of putting together a comprehensive multidisciplinary clinic. That's an enormous amount of vision and persistence to put together a team like that. So whether you're in your future leading a cancer care team or the ideal trauma patients or, you know, amputees, whatever it is that you're working with for trainees in the future, I'm wondering if you can talk a little bit about looking back at putting the team together and getting the hospital support that you needed, the equipment you needed. What would your advice be to people about how to start that trip? If you started with building your collaborative clinician team, do you start with approaching a hospital for idea that you have that support that you need? How would you advise people building the ideal care team?
For that initial first step, I think I would have 2 pieces of advice. One that I hope I don't get in trouble for saying on a recorded Zoom. The first, that is non-controversial, is find your friends. Everybody in this picture here, they are truly wonderful human beings. We are all committed to this vision together and taking care of these patients together. And when you find those people who are interested in this and really inspired by the potential of building this team for providing comprehensive care instead of being within our own silos, I think that is the great place to start. And then with that momentum, then it really gives you the energy to fight through a lot of the other roadblocks that you have. The thing that I might get in trouble for is ask for forgiveness, not for permission, because if I had proposed to the hospital administration from day one, hey, I want to build this, and these are the patients that we're going to see, and these are random numbers that I'm pulling out of the air for our volumes, that never would have gotten off the ground. So I found my team. We all rearranged our schedules behind the scenes. We said Friday is going to be our clinic day. Thursday, we're going to have people available to do EMGs. hey, MRI team, can you help with radiology scheduling so that we can get patients in? Everything sort of worked out behind the scenes. And then after that first 9-12 months, we were able to do a pro forma with the hospital and say, hey, now we've built it. This is how many patients we've served. These are, the number of surgeries that we've done, and we're only growing from there. So being able to really just start it kind of under the radar a little bit, demonstrate the value, and now the expansion. If you look at our clinic numbers, it's just astronomical growth. Really just starting with that idea of being very passionate about it, pushing forward, and then having a little bit of a big picture. What is the hospital looking for? What are things that they care about as far as metrics, and figuring out how to get those to support the continued growth.
And I have one from the Zoom. There are a lot of amazing, phenomenal work, great comments, as well as a question here. This is from Dr. Young. The role of the microenvironment is critical to nerve injury and recovery. Can you comment on the role of the immune cells and the response to nerve regeneration? Figure that's rough.
Thank you. Excellent question. I think that is an area of nerve regeneration research that I'm actually actively trying to avoid, because there are a lot of other prominent labs within that space. So I don't want to bring my relative lack of expertise into that, because I don't feel like that's where I'm contributing the most. I think as we talk about nerve regeneration, one of the first things that does have to happen is macrophage infiltration. That has to clear out the debris. Imagine, that one green picture that I showed of those little tubes. The macrophages do have to come in and clear that out to allow the nerves to regenerate. And when that process is faulty, the nerves don't regenerate as well. I actually have a new collaborator over at South Lake Union as well that is interested in the immune cells, specifically T cells, in the development of neuromas and neuroma pain. And unfortunately, she and I don't have enough data yet to show you, but hopefully soon. I think it's been a really fruitful collaboration in that her lab really focuses on neuroma and pain, and I see a lot of neuroma patients. So I'm able to give her those surgical specimens to do those analyses with.
So reiterate what Dr. Wood said, wow. What makes UW so great is our ability to collaborate. And this is just an example of that. And I thank Dr. Wood for the support, but one person who I want to thank, who saw in you what you are and made this happen, is Dr. David Flum. So hey, thank you for that. And a question, comment you asked, how do we best measure this stuff? We have the different motor scales, we have which century, but it's really, what does it mean for the patient? So what we need is a validated patient reported outcomes tool for nerve. We need to have nerve to something like that. Think about something.
Yeah, I think that's a very astute comment, and definitely things that we're working on. I think what I presented today probably captures about 30% of what I'm actually working on, and I could talk about nerves forever and ever. We are part of several multi-institutional collaborations to do just that. One specifically on brachial plexus injuries, which is an NIH-sponsored study, and then another one with a group in Canada to develop something that is more peripheral, not just brachial plexus related. And we are really starting it at the instrument level, coming up with questions, going through all of the different phases of asking clinicians, asking patients, and then eventually looking at how responsive those are. Again, with that long delay of when we're doing the surgery, and then we have to collect things at 1 year when it's actually too early, 2 years, 3 years, 5 years, to see what is actually impactful. I think until we get there, hopefully in 5 to 10 years, there are other things that we're actively developing alongside these collaborators, things like wearable technologies to see whether that can be a metric for how useful that limb becomes. So we're not relying on that one snapshot of that clinical exam in time, but looking at how they're using their arm as they regain function over time. And I think things like that would be really powerful, video-based assessments, things like that, to be able to do things a little bit more remotely as well. So a lot of things on the horizon, a lot of exciting things in the field.
Awesome. 2 questions. How do you address muscle loss atrophy that happens to teenagers? Are there ways to improve that, or is it simply just therapy? Other questions. Are your techniques applicable for any non-traumatic inflammatory disorders?
Yeah, that's a great question. I think that, and again, I'll start with the second question first. The inflammatory issues with nerves, that is totally unknown. I have already wavered multiple times on whether they should be surgical issues or non-surgical issues. I think there are a lot of people in the field that do decompression surgeries when we can see a focal site where there seems to be an inflammatory response that might be causing a compression on the nerve itself, trying to go in there and decompress it. I have not had good results in my hands, at least with those types of patients. And so now the question is, well, because these are time-sensitive injuries, do we just treat them like traumatic nerve injuries, give them some of their function back with nerve transfers, which we know to be very reliable? That I don't know. I think that is actually something that I've been thinking about a long time, about maybe a PCORI trial to see what patients would prefer. Would they prefer to avoid surgery and see what happens, knowing the state of the literature that most of them get better, or would they rather have an earlier intervention at 3 to 6 months post onset when they feel like they have plateaued and know that they're going to get function better at X time point after surgery? To address the first question that you had about muscle atrophy, I think that is really challenging. And there's a difference in muscle atrophy of muscles that are just disuse atrophy versus denervated muscle atrophy. And so I think in the physical therapy world, there are a lot of people who are doing direct muscle stimulation on the denervated muscles, which I believe very strongly we should absolutely not be doing. I think that the muscle itself actually releases some neurotrophic factors when it's denervated. And so if you are preventing the muscle from releasing those factors and you're saying, oh, you're not actually atrophic, you're fine, it's actually going to prevent the nerve once it gets there from forming these new neuromuscular junctions. So that is definitely something. Actually, I have another surgeon scientist friend in Indiana who is actively studying that. But I think that there's a very different way to treat that. I think once the nerve actually makes that out to the muscle, we know that there is healthy nerve supply to the muscle, then it's really about strengthening at that point.
Thank you so much, Dr.
Thank you.